Okay. My name's Javed Rehman. I had a mental health breakdown, so my personal lived experience, has lasted me for about 20 years. I also got experience as a carer, so I've seen all the different changes throughout the NHS and the systematic changes and how people relate to or try to intervene with South Asian communities, etc. Fantastic presentations from Busra and Caroline. Two things straight away that I picked out when we mentioned countries and South Asian. One thing that got missed, and this is not their fault, it's the way the data is collected in the UK. Like, I'm from a Kashmir background, but Kashmir is technically classified as Pakistani, or you got the disputed territory. But a lot of the Pakistani population within the UK, I would say about 70% would be from the Kashmir background. So therefore, like, their language is different, their culture is different, their behavior is different, the academic achievement is different. So all these little micro aggressions, as you may call it, will impact the study. So unless you get someone that's prepared to come forward and say, excuse me, I don't belong to that particular box, it will not change. So, like, my experience going through the mental health service was that today is probably a good day because I haven't been shaving for about a couple of months. I got referred to the prevent team. So, and luckily for me, the person that turned up from the prevent team, it was someone that I did a course with him. For people that don't know what the prevent team is, it's anti-terrorism. So therefore, like, having a beard, that's social profiling. There's a very fine line between safeguarding and someone being a danger in the public domain, i.e. being a terrorist. So I stopped engaging in terms of to get my own mental health sorted out. I have to deal with it myself. I am not going to make myself vulnerable and open up anymore because I do not trust the system. I think the system is institutionally racist. So therefore, it makes it harder for me to access and say, are you going to send me back? What are you going to think about me? Can you actually deal with me? Do you understand me? Then, like, for example, with me being from the South Asian or Kashmir background, born and bred in the UK, so I am a British Muslim first. That's how I identify myself. And what I would say, like, in the UK, it's people get pigeonholed into boxes without them realizing, or be socially conditioned by society, news, media, etc., to belong to a particular box or change their behavior. Most of the research that gets applied to minority communities or communities facing racial inequalities is generally white Eurocentric based. So therefore, it makes the impact and change and recovery rates, it becomes significantly harder. And there was talk about hospital rates and doing self-harm. I've been to hospital several times with self-harm. Not once did they pick up that I was a mental health patient. Triage, as soon as they saw when they should have seen my medication list, it's quite obvious I'm a mental health patient. So they put a plaster on me, off you go. Because what it is, if you create an environment where they have to spend more time, etc., because they key performance indicators, it has an impact on the care. And also the stigma related to openly talking about your mental health conditions, etc., it's quite difficult in the South Asian or Black communities or communities facing racial inequalities. And on top of that, in some of the languages, some of the terminology does not even exist at all. So you as a clinician might be sat there thinking, yes, this is getting translated. Yet the person on the other side thinking, why the hell is he calling me stupid? Why is he calling me this? Because your interpreters are not always trained to translate there's words, because there are no words. So sometimes you have to use analogy. You get a poor interpreter, that patient's gonna think, I'm not coming back again. They think I'm stupid. And then you got all the other microaggressions within these communities, black magic, like for example, I belong to the South Asian community. I wear 4 different hats, one for home, one for the community, one for work or in my professional environment, and one with my friends. So who are you going to treat? When I come in there, who are you going to treat? They all will be interlinked, but at the time, who are you going to treat? And that's a very big question mark, realizing the microaggressions that are within these minority communities, that unless you're from those communities, you will not recognize them or know that they exist. And we talked about commissioners and clinicians. Unfortunately, equality impact assessments are very poorly written. Commissioners do not recognize how to deal with people from minority communities. You don't even look at the local data in terms of ethnographic data and languages, etc. So they could get more tailored services in place for them communities to make an impact. Yet they keep making these large commissioning projects that are there for like a couple of years and then they disappear. And the other problem is these communities are fed up of being consulted to death and not seeing any outcomes, not seeing any results. If you don't understand me, you don't want to listen to me, you're going to do what you want to do in the first place. Why have you come to talk to me? So this is a very key point, and the language is very important because mental health, generally speaking, historically, everyone knows it's been always associated with very bad connotations. Like a schizophrenic is going to harm you. They're going to be out of control. Like they won't be able to be anyone in their life. So and one of the key things that I read several years ago, which I find really inspiring, Dr. Elmer Sykes, who was about 7 or 8 years old, diagnosed with schizophrenia, and was told, you will not be anything in your life, like to a professional, in terms of a professional career. She became a professor. Still got schizophrenia, but she became a professor. Society does not allow people with mental health conditions to progress as they should because they put up barriers due to social conditioning and the subconscious biases. And until you recognize your subconscious biases, you will not make progress. In terms of cultural competency, you have to admit that you do not know. Ask questions. Any training course that you go on in regards to cultural competency, it doesn't make you culturally competent. It starts you on the journey to become more culturally competent, and ask those questions that normally you would think, that's a silly question. I'm not sure how to put it across, but you will be surprised how many people will be open up and discuss that. And one thing that wasn't shared in something, religion plays a very big part. And the system, when I go in, I'm a number. I'm not a patient, I'm a number. When someone else goes in, they're a number. You've got 3 weeks to get him in and out of the system. Paperwork doesn't always tally up. Same questions. And even in terms of equality, EDI, equality, diversity, and inclusion, there's nothing happening. How many clinicians do you see from the South Asian or any ethnic background? Because for them to progress to a higher level, it's virtually impossible because they speak multiple languages and are slightly more culturally sensitive, not competent, sensitive. They are not likely to progress because they're making a better impact at the front line, but they can't progress their careers. So then we talk about intersectionality. So like I said earlier, I'm British, I'm a Muslim, I'm from a Kashmir background. I identify myself as a he as a him. I'm a person with disabilities. You could say I'm a person of color. You know, like my religion, even that has an impact on where I'm profiled. So social profiling makes a significant impact. And in order to make change, research needs to change. But unfortunately, research goes on evidence-based or the stats and data.
I've muted, but it's not.
Research is unfortunately is limited in how they categorize the coding, even to the extent the NHS still use the word retarded for people with learning disabilities, which I will be sharing the report later on when the slides go out. And I've been telling the system for about since 2017, and I'm making very slow progress. I'm making progress, but slow progress. It's tiring, but I'm making progress because I sit on the BABCP on the course accreditation board. So I basically I'm there saying, look, where's the module on cultural competency? The communities are diverse. Like we are like an international, like society. So when are the students going to learn? And I also do talks to final year students where I go across. Sometimes I ask them awkward questions to make them think, hold on, do I know about that? Because sometimes they qualify, go into the community, then realize, I don't know much about these communities. So how do I adapt my knowledge? Who do I go to for help? Will they help me? Or will they see me as incompetent? Will it impact my career progression? So, like the whole system, unfortunately, it's getting there, but not perfect. And what I would say, please, the people that are writing equality impact assessments, please look at your local data in terms of ethnographics and languages, and also check if the languages have the right terminologies. And do not presume, do not presume or make an assumption, then it will definitely be wrong. Co-production is the key, to make services better. Because I'm quite happy to tell you how to engage, but you don't come and ask me. If you don't come and ask me, you're not going to engage me. It's simple as that. You should come to me, not me come to you. I'm going to leave it there for now. And I hope you enjoy some of the documents I'm going to send out later. Thank you, everyone.